Good morning, everyone. Today we're going to learn how to monitor patients in shock while they are being resuscitated. This is important for saving precious lives as well as for acing your exams. Okay, now, the minimum standards for monitoring of the patient in shock includes continuous monitoring of heart rate on a cardiac monitor, measuring oxygen saturation with a saturation probe, blood pressure measurements at regular intervals, and hourly urine output measurements. It's important to know that some patients may need one of the 4 additional, more aggressive and invasive monitorings, including central venous pressure, CVP, invasive blood pressure monitoring through an arterial line, cardiac output measurements with echocardiography, and, lastly, measuring the organ perfusion. Organ perfusion can be done through 2 ways. Firstly, through arterial blood gases by calculating base deficit and serum lactate, and secondly by measuring mixed venous oxygen saturation. Today we'll briefly discuss the CVP, urine output, cardiac output, and organ perfusion measurements. Let's start with the central venous pressure. We must remember that there are no normal values of CVP for a patient in shock, so the range cannot be generalized. Some patients may require a CVP of 5 centimeters of water, whereas some may require a CVP of 15 centimeters of water or higher. Having said that, the CVP measurements should be assessed as the response to a fluid challenge. So ideally a fluid bolus, 250 to 500 ml of crystalloid. Ringer's lactate is infused rapidly over 5 to 10 minutes. There can be 3 possible responses. Firstly, there can be a normal response in which CVP has a rise of 2 to 5 centimeters of water, which gradually drifts back to the original level over 10 to 20 minutes. Secondly, there can be no change in CVP in response to the fluid given. Such patients are hypovolemic and so give them more fluids. And thirdly, that the patients may have a sustained rise in CVP. This means that such patients have an element of either cardiac insufficiency or a volume overload. Next, let's discuss cardiac output monitoring through echocardiography. Although other modalities are also available for cardiac output measurement, the echocardiography is non-invasive and provides real-time imaging of the heart. It can estimate cardiac output using Doppler flow measurements. It is very useful for assessing cardiac function and diagnosing underlying causes of shock. Furthermore, this information of cardiac output guides regarding fluid and vasopressor therapy. Next, let's have a look at the urine output. We all know that ultimately the goal of treatment is to restore cellular and organ perfusion. Ideally, therefore, our monitoring of organ perfusion should guide the management of shock. The best measure of organ perfusion and the best monitor of the adequacy of shock therapy remains the urine output. The normal urine output is 0.5 milliliters to 1 milliliter per kilogram body weight per hour. In addition to urine output, the level of consciousness is an important marker of cerebral perfusion, but we must keep in mind that the brain perfusion is maintained until very late stages of shock. Due to these shortcomings, currently the 2 main clinical indicators of perfusion of the gastrointestinal tract and muscular beds include ABG analysis for lactic acidosis with lactate and base deficit and the mixed venous oxygen saturation. Let's first discuss the lactic acidosis. We already know that the lactic acid is generated by cells undergoing anaerobic respiration. The degree of lactic acidosis, as measured by serum lactate level and the base deficit, is sensitive for both diagnosis of shock and monitoring the response to therapy. Patients with a base deficit of more than 6 millimoles per liter have a much higher morbidity and mortality than those with no metabolic acidosis. Furthermore, the length of time in shock with an increased base deficit is important, even if all other vital signs have returned to normal. These parameters are measured from arterial blood gas analyses, and therefore the frequency of measurements is limited. Nevertheless, the base deficit and lactate should be measured routinely in these patients until they have returned to normal levels. Now let's discuss the mixed venous oxygen saturation. The percentage saturation of oxygen returning to the heart from the body is a measure of the oxygen delivery and extraction by the tissues. Accurate measurement is via analysis of blood drawn from a long central line placed in the right atrium. Normal mixed venous oxygen saturation levels are 50 to 70%. Levels below 50% indicate inadequate oxygen delivery and increased oxygen extraction by the cells. This is consistent with hypovolemic or cardiogenic shock. Patients who have a septic shock should have mixed venous oxygen saturations above 70%, and below this level, they are not only in septic shock but also in hypovolemic or cardiogenic shock. New methods for monitoring regional tissue perfusion and oxygenation are becoming available, the most promising of which are muscle tissue oxygen probes, near-infrared spectroscopy (NIRS), and lastly, sublingual capnometry. While these techniques provide information regarding perfusion of specific tissues, it is as yet unclear whether there are significant advantages over existing measurements of tissue hypoperfusion, that is, base deficit and lactate levels. Thanks everyone for your attention. Always stay blessed and happy learning.